Good morning, everybody. It's a great pleasure to be here, as always. I'm just going to go through a case of a gentleman that I've been seeing in clinic over the past year or so, and I hope it's useful for us to reflect on drug-drug interactions and how much. It's just going to show you how much we use the Liverpool website. So, this is a gentleman that was diagnosed with HIV in 1993 with a low CD4 count, so quite advanced disease. And when I met him in 2004, his CD4 count was 380 and his viral load was undetectable, but he was 61 years of age and presented with multimorbidity, which is quite a common scenario we see in our HIV patient settings. And this brings me just to a reflection for everybody in the field. Whatever you do, please remember that people who have been diagnosed with HIV a long time ago present to the clinic with polymorbidity and polypharmacy. And this, I say, it's important for us all, clinicians, pharmacists, pharmacologists, researchers, because this is really a group of people that require our research and require our attention. And the JEPO study, which is a cohort study happening in Italy and looking at comorbidities in people aging with HIV, actually found that it is the length of HIV diagnosis, the real factor associated with presented with higher levels of multimorbidity and polypharmacy. So these are the people that when you see or when you manage, you have to really stop and think, because they need a lot of your time. And I always say, thank you for the Liverpool website, because that's about an hour on the website rather than, 6-7 hours on your own going through summary of product characteristics, trying to figure out what the drug interactions are. So this gentleman, as I said, was diagnosed in 1993 in Australia, moved to the UK, and had many opportunistic infections, admissions into hospitals, toxoplasmosis, PCP, MAC, so quite an intense history of HIV associated opportunistic infections. Also, as you can see, I'm not going through this, a very rich antiretroviral history, a lot of NRTIs, NNRTIs, all boosted protease inhibitors, and again, complex, both life, mental, and physical health factors throughout. He had a very important period of depression when his mother died, and stopped and started and failed regimens. So when I met him in January 2024, he was on TAF, FTC, and darunavir twice daily, and he was referred to our multidisciplinary team because at the time we were starting a clinical trial with fostemsavir, and the trial was aimed at replacing boosted protease inhibitors with fostemsavir, an optimal background regimen in people who had no other choices. So obviously the objective is to remove, combinations of antiretrovirals characterized by a high potential for drug-drug interactions, especially again in people aging with multiple complexities and including polypharmacy, and therefore being at higher risk for drug-drug interactions. These are his cumulative resistant test results. You can see multiple NRTI resistance mutations. Now, for the clinicians in the room, this is the interpretation, or the virologists, if there are any. Nowadays, the high genetic barrier integrase inhibitors have been shown to work with a very good number of background mutations. The data presented at CROI this year actually showed that if you have 3 times in the 184V, the combination of tough FTC and Biktarvy is probably effective. This is all well beyond the summary product characteristic and license, but in clinical practice, we do it a lot. However, what we don't know is where is our limit? Like, is it 3 times, 2 times? I'm looking at Say and Steve, I don't know what you guys do, and I'm sure you have long conversation, individualized care conversation about this. Is it 4 times, 5 times, 3 times, 184V plus or minus? What is actually do? For this gentleman, we thought that because of his history, it was probably safer to combine the tough FTC BIC with something else. But I promise you, we have very lengthy conversation on whether that this is needed or not. And also, the DHHS guidelines and many others still say that we need to prescribe 2 or even 3 in people with multi-drug resistance active drugs and list all the new drugs that would bring a benefit in this kind of people. So we are picking on fostemsavir because this is what happened in my case. Fostemsavir is a prodrug that is converted to temsavir, which is the active drug, and it is the drug that is absorbed. So temsavir is not really metabolized by cytochrome P453A4 and doesn't inhibit or induce cytochrome P453A4, however, inhibits ATP and BCRP. So there might be some drug-drug interactions at the level of transmembrane transporters. So this is what my research fellows do every time someone that is eligible for the fostemsavir studies come in. They go on the Liverpool website and they go through every single drug because we are switching from darunavir-ritonavir to fostemsavir. And believe me, it does require a thorough review. So we're talking about drugs that are again, responsible for different drug-drug interactions in the context of the mechanism. And then obviously, let's not forget that there's an optimized background there. So we're talking about tough FTC and bictegravir. So, you can see here, I'm very happy to go through it in detail, but, you can see here that we're going from over-the-counter, from darunavir-ritonavir, that we're not very worried about, into bictegravir, where there might be some absorption interaction, so you need to remember to tell them to take bictegravir with food if they're on any supplements that contains divalent cations, for example. Other vitamins are okay. We're moving from some drugs like diazepam, zopiclone, where cytochrome P450 is involved in their metabolism, to so it's from orange on darunavir-ritonavir to green on bictegravir and fostemsavir, because we are removing the cytochrome P450 3A4 inhibitor. We're removing the ritonavir. We are moving to fostemsavir that might lead to QT prolongation. So you can see that there's a bit of a change on citalopram from yellow to orange as an advice. What I do in practice, and please feel free to disagree, is that rather than not prescribe the drug when there is a QT risk, maybe monitor, maybe do an X-ray ECG if it's possible, but I would not prescribe a drug because of that. Now, obviously, we are talking in this case about clinical trials, which is much more complex, but makes our life easier because the monitoring is already happening as part of the trial. Mirtazepine, we're going this time from an orange, probably because of the metabolism with 3A4, to a yellow, not a green, because of the QTC potential prolongation. The statins are very interesting because with the inhibition of the transmembrane transporter by fostemsavir, we are now actually completely removing the drug-drug interactions concern that we might have with ritonavir or cobicistat. So we are actually staying 10 on 10. What we don't know is that in people aging with HIV, with polymorbidity, with high cardiovascular risk, with already established cardiovascular disease, how much statin do we need when these drug-drug interactions happen? Does the statin actually get into the liver and works and delivers their effect? So we are moving from inhibiting transmembrane transporters and cytochrome P453A4 to inhibiting still transmembrane transporters. I have to be honest with you, the dose of statin in the context of drug-drug interactions is challenging. And we know if you speak with a cardiologist, they are obsessed about the higher. It's never enough, higher. The dose of statin needs to be higher. Your LDL has to be below 1.8. Sorry, I'm using the British ranges, but like obsessively, why we are much more, that's why we did infectious diseases and pharmacology, we are much more relaxed. So just for you to know, there are very many reflections to do in the context of primary and secondary prevention. I would have given him more atorvastatin, for example. Amlodipine is okay. We're moving from a 3A4 inhibition situation to nothing to worry about, which is great. Omeprazole is fine, and then one of the main things for him is that removing the ritonavir allowed him to have beta steroids for his acute when the COPD becomes acute. So that's also very useful. I would highly recommend to take the opportunity to measure the anticholinergic burden score for someone that you review so thoroughly. And his was actually 4, which is quite high. So anything we can do to improve this and decrease the anticholinergic score, which is very rarely done in this population, again, of people on very, very important polypharmacy. So there is another thing that happened that it's worth reflecting on during the study. So he switched to TAF-FTC, Bictegravir and fostemsavir. And at the beginning, he was fine. He felt much better. And then he came with major mental health concerns and depression. He lost a lot of weight. He wasn't eating. And we asked him whether he wanted to drop out of the study, whether he wanted to switch his treatment. And he said, no, I want to try a little bit more. I had this level of depression in the past. I know I can do it. He kept coming in because, again, it's a trial. So we were seeing him very frequently. And we were very concerned about his mental health. He was referred back to the multidisciplinary team that said we have to switch him. At least let's try to switch Bictegravir to dolutegravir. Very similar drugs, but sometimes we do, sometimes it works, sometimes it doesn't. And he completely denied. He said, I don't want to switch. I've never felt better physically. He was coming from darunavir, ritonavir twice a day. So I've never been felt better physically. I don't want to switch. It was really, I have to say, it was a little bit beyond what I would do. But that's also a lesson, because people living with HIV that start a new treatment have side effects, come back to clinic and ask you to switch. This was very much the other way around, so a little bit unusual. Interestingly, we referred him to his psychiatrist again. We made sure he had all the support, including peer support, that we could give him. He changed citalopram to escitalopram. He increased his mirtazapine dose. Anyway, believe me, he came back very happy. It took a while. We were worried, but he came back very happy, and he said, this is where I wanted to get. I'm now happy, which for me was a massive lesson on when all you have is the high genetic barrier integrase inhibitors. Maybe it's worth waiting and listening and discussing and talking rather than rushing into switching. Again, going back to the anticholinergic burden, we were able, because it was much better from a mental health point of view. He says his anxiety was remarkably lower. We were able to stop the diazepam, to replace omeprazole with the esomeprazole, and actually increase his ACB to 2. So that's something that, again, I highly recommend it to do. in all of these people you see on polypharmacy. And again, and this is my, my adverse event reflection, as I was saying, we are really sometimes rushing to switch and reswitch and finding solutions. We're talking about an incredibly complex population. We're talking about people, as I say, you know, with a high level of multimorbidity and on polypharmacy. It doesn't take a week to adapt to a new drug. It doesn't take a week to understand what the side effects are. And drug-drug interactions also, it might take a while for them to establish or not, or resolve. Obviously, we don't do any drug levels of any of that. It's all highly theoretical. But the fact that we were able to wait, talk about it, adjust his mental health drug and leave him on a combination that is incredibly modern, associated to much less metabolic side effects, short-term and long-term, and also really try to improve his quality of life by being able to co-administer the multiple medications that, again, it's not that drug-drug interactions are gone, but slightly, definitely easier than ritonavir, and also other potential co-medication that he will need to add will be easier to add, was incredible. And as I say, this is just an example, and he might come back one day and say, I am very tired to be on a twice-a-day drug. We might have lenacapavir approved in the UK, and he could actually go on one pill once a day, the Biktarvy, and lenacapavir 2 injections a year, and then you're going to have to do all of this again. But if you have some very good clinical fellows, they love to go, and they come with this kind of report printed out into the patient's bed. And I said, oh my goodness. But this is really how you teach about drug-drug interactions in my experience. Thank you so much. Very happy to take questions.